Thank you very much, and thank you very much, Brendan. For those of you that sort of spend much time talking to me, you would hear that a lot of what Brendan said sort of comes out of my mouth as well quite regularly. So, and you'll hear a bit more of some of the workforce reform in some of what I get to speak about today. I think the first thing we need to do is sort of look about where we are this year and where we've got to go to next year. And I think that that's sort of going to drive a lot of some of the work that we need to do in the future, just in the very short term, let alone some of the things that Brendan was talking about, where we're moving into an environment, ageing population, very high needs, and also the fact that we've got a lot of people that we're not even accessing services at the moment. So we've got some real challenges before us that I think require an enormous amount of intellectual sort of effort put into to try and think of new ways about the way we can deliver care. In Victoria in the last year, because of Commonwealth funding, we've had some very significant sort of funding base, a lot more than we've had for a long time. I think for those of you who've been around for a while, certainly since the Commonwealth General Health Program was the last time we had really huge influxes of money. And here we are back again with having had a whole pile of money to deal with, and I'd like to sort of thank all of you for the huge efforts you've made, because we've actually delivered all those services extremely well, ahead of schedule, and there's over 100,000 people in the state of Victoria that have received care over and above what we've ever done before. So a really, really significant effort on everybody's part. And waiting times are right down. I hear people ringing me all the time talking about how they have no waiting lists, although people are saying now they're starting to notice them go up, because more people now are coming to us and demanding care. I think the other thing that's now we need to look at is the challenges before us for next year. As Mick has indicated, the national partnership, the second national partnership agreement has been delayed, and we need to deal with that. And it may, I've still got my rose-coloured glasses on and hoping that it will continue, and it has just been delayed, but there is a potential that it's going to never ever happen. And so we actually have to deal with that, because we still have people knocking on our front door every day asking for care, and we have an obligation to try and find smart ways of delivering that care. So we're going to have pretty ambitious targets for this coming year, and that does mean that we need to be very innovative. I think one of the things we have to remind ourselves, and I just put this slide up as a bit of a reminder for all of us, is that when you look at oral health and oral disease, most of it is largely preventable. And we don't seem to have progressed very far, and I found that I was out of the dental sector for about a decade, came back into it, and was sort of almost a little bit disillusioned when I came back into it, thinking, why haven't we actually made a difference? What has stopped us from actually starting to prevent some of this disease? We're still, and I think in the public sector the biggest issue is we deal with such a small number of people, and we're so overwhelmed that we just do what we can for those small number of people. But from an overall perspective, are we really making a difference? And so when you look at, tooth decay still being very, lots of children still have tooth decay. Most people at some stage experience some sort of oral disease. We really need to be thinking with our model of care, how can we really make a difference? And we also need to remind ourselves that most of the risk factors associated with oral diseases are the same risk factors that are associated with lots of other general health. And you find more and more medical practitioners and nursing colleagues, etc., who will really recognise the fact that oral health has a significant effect on the patients that they treat in their environments. And we need to be a lot better at recognising that we should be working with our other health and caring colleagues, because if we can work in collaboration with those people, maybe we can start to improve the oral health of our patients. And I think you've noticed that a lot of us are all doing little bits and pieces in that space, but we probably need a much stronger concerted effort. I'll just talk a little bit about model of care, and then I'm going to go away from it and then come back to it. But At DHSV, we spent a bit of time talking about what does model of care mean, what are we thinking about, what are we trying to do, because a lot of people have just never... It's not a conversation that in dentistry we've used a lot. It is very, very normal in the general health arena, and people have been talking about it for quite a few decades, in fact, but more so in the last decade. And we in dentistry really haven't done a lot in that space, and we probably need to. And I think it's about intellectually thinking about who are we going to be treating, why are we treating them, what are we going to be doing for them, how are we going to make it all happen. And so it is a new and different approach to the way we do our business. It's not about doing the same old thing, as Mick said earlier, that definition of insanity. We know if we just keep going and doing the same old thing, we are still going to have all those people with decay, all those people with perio. We're not actually going to be improving oral health. So we need to be a lot smarter about what we're doing. And we also need to make sure that we are providing better health outcomes, not just patching things up, but we're actually making people better. And that's a really important part of a model of care. And we want to treat more people. We only treat about 20% of that 30% that are eligible, and we could do so much more if we were smart about what we did. And I think that's the challenge before all of us at the moment, is how can we make sure that we develop a model of care that can treat more people with less money that we're going to have next year. When you look at models of care, they need to be patient-centred. And I think Brendan picked up on a lot of that. We need to make sure that we keep that focus on our patients. Some people would say they have to be family-centred. It doesn't really matter, but you are looking at that person and the people around them and centring the care around them. It needs to be multidisciplinary. And with multidisciplinary, it is about that team approach to providing the care. And a lot of what Brendan was saying before about different people within in the care team can actually provide the services. And I'm also a very strong advocate, is there are a lot of people in other health arenas that touch our patients every day that could have so much more effect than what we can when we only see them once every couple of years, if they come at all. So we've got to use those people as being our champions for improving oral health as well. And there's certainly been a lot of work done with midwives and maternal and child health nurses, etc., to do that, but we've got to do a lot more. The collaboration is obviously important. Team-based and working with our other carers is also important. It needs to be evidence-based. There is a lot of care that we do that hasn't necessarily got evidence to support it. That's right across the health sector. We're not Robinson Crusoe with respect to that. But there's certainly a lot of emphasis, I think, on us moving towards more evidence-based care. We want to focus on prevention and early intervention, and most of us, I've been hearing that since I graduated, and I think most of the people in this room have. But we sometimes forget it when we get into that clinical environment and somebody's knocking on the door with a toothache or pain, and we need to deal with that particular situation. I'm very strong on the view we need to maximise workforce potential. Having worked in a number of different states, I see some things that in the past, before the national registration, were legal in one state and not in another, and it's just crazy that we can't. And it was certainly safe in those environments in another state, but supposedly not safe in another. And we do need to make sure that we have really satisfying jobs, and we can do that by sharing that around. And I'll talk a bit more on that a bit later. And lastly, we need to focus on treatment with value. And one of the things that there's a growing body of evidence is that most of the services that, well not most, a lot of services we provide in health are of either no value or low value. And we need to move towards making sure that the services are of high value. And in fact, one of my latest, I usually have some particular article that's my favourite at the time, and I bombard it to all the people that I know and love. So there's a few people cringing here because I've sent this one off recently. This is my favourite article at the moment, and it's by Associate Professor Ian Scott, who's an internal medicine professor. And he's just written, it's just about to be published at the moment, but he's written this, this article which I managed to see pre-publication. But it's talking about some strategies for value-based care that are clinician-driven. And he talks about a number of these things. And while this was all predominantly from an acute care background or internal medicine background, when you actually go through and look, it was absolutely totally applicable in a dental scenario. And if we started looking at our workforce reform and then also started looking at value-based care, I think we could make a really significant difference to thinking about the types of services we do. So the key things that they were talking about is there should be minimal errors in diagnosis. And, you know, that's all very easy to say, but there are lots of things that we do. If we make that wrong mistake in diagnosis, it can often cause quite expensive care along the way later. We need to discontinue those low or no value practices that provide little benefit or harm. And I used to see that a lot in acute care, and I know that there's lots of that happening in dental. I mean, I used to see quite often, I'd make the most beautiful partial denture that I thought was fitted perfectly, and it spent most of the time, and it fitted really well in that bottom drawer. It didn't get used, and we find that happens all the time. We quite often are doing treatments on people that they either don't like and don't use. We need to defer the use of unproven interventions. I think particularly that we're in a public sector, we should be delaying the going off and using something that's the newest, brightest idea until it's actually proven, because you can go a long way and spend quite a lot of money before you actually make a difference. We need to select care options according to the comparative cost effectiveness. I mean, this is particularly relevant in acute sector where you can have huge differential in cost for particular products without any difference in health outcome. But we have that in dentistry too. And we need to start thinking about those things and saying, we've got 2 or 3 options. Well, why are we choosing this expensive one? Is it because it's the latest new gadget and toy, or is it because it actually adds better value to our patients? We need to adopt a more conservative approach towards the end of life. Now, while that is, as Brendan said, something that happens in the acute sector, it actually also happens in our sector as well. We have a lot of people in aged care facilities that we're treating, the types of services we provide. We need to make them applicable, more quality of life as being the key driver. And I think a lot of our people who work in dom care and work in aged care, they would already be great advocates for that, but we all need to learn from them about some of those sort of decisions and treatment planning that we need to provide. We also need to actively involve patients in shared decision making. I mean, that is part of national standards anyway, and it's something we should be doing. But it is amazing how often you find that people don't really understand what you're doing to them because they haven't understood it, and then afterwards go, actually, I didn't really want that. And that's where sometimes we might be doing some pretty over-the-top treatment, and there's a lot of evidence to show that if people are giving choices, they often will choose a simpler, often less expensive treatment choice. We need to minimise day-to-day operational waste. I mean, I think we do a lot in that space, but we could do a lot more, and some of that's even just in the treatment decisions as well. We need to convert healthcare institutions into rapidly learning organisations. And what they mean by that is, what he means by that is, don't go and do those big, long research exercises. But what you need to do is, if you are testing a new part of a model of care, you review it, you see how it's going, you do some evaluation, and then you might adjust, because you've got to be nimble, you've got to be quick, and you've got to be able to reflect the fact that something isn't working, you need to move on and change until you find what works for that particular community. And lastly, advocating for integrated systems of care that maximise the value. And I think that's particularly relevant in a model of care where you work with people like maternal and childcare nurses, midwives, all sorts of different people, GPs, to actually help provide the care for your service. So this is something I think that we need clinicians to drive this. We can't do this. This is not something that from an administration point of view you go, here's a model of care, you make the call. We actually need people like yourselves to be standing up going, okay, we're going to sit down and work out how we're going to design a model of care that's of high value. So I suppose just in summary of that particular area, I'm saying we need to stop doing things that are of no value and start doing things that have got strong value or high value, evidence base. We need to actually make sure that what we're doing makes a difference and is improving oral health, rather than there are some things I think that we do that don't necessarily do that, but they're the things that we've traditionally thought that would make a difference. I mean, I look back on some of the things that I've done in the past and I feel almost a bit embarrassed, but at the time they were the things that were the right thing to do. There wasn't necessarily evidence to support it, and now I look back and thought, well, I probably didn't actually help those people, or I didn't improve their life at all, or improve their oral health. And that's the sort of thing I think we need to constantly be looking at the work we do, saying, am I making a difference? Am I improving people's oral health? So in our model of care deliberations so far with DHSV, we've looked at a set of principles that should drive us in the model of care. We've looked at the patient journey, and we can spend a lot of time moving our poor patients around. I often think that, and particularly coming into the hospital, some of those patients deserve a medal, the fact that they've managed to get through the place, because it's really complicated. We've got all these access barriers along the way, and we've created them over the time in response to either different policies or different procedures or trying to improve things. And when you actually sit down and map what we put the poor people through, it is quite time-consuming. So what we're starting to do is to start to break down some of those barriers and try and make it simpler and easier. And I know that a lot of the work that you have done in your particular clinics have also done the same sort of thing. We've also analysed a lot of the factors that impact upon our oral health so that we can look at where there are linkages and what we can do to improve oral health, and where we can integrate messages into general health area. We would love to make sure that when we've got like yesterday, the Cancer Council, they put out a press release in relation about sugary drinks. We want to make sure with the Heart Foundation, with Diabetes Australia, with all of the different players that we've got common risk factors with, we want to make sure that we're out on the same page with the same messages. We don't necessarily it has to be an oral health message. It actually has to be a message that improves oral health. And we've got to be there supporting those messages. And we also need to develop a very new approach to the way a patient goes through the process. And some of it might be that we go to patients rather than they come to us. We may be looking at the sorts of care that we provide and whether we actually need to provide it the way we've been providing it so far. Just to give you a couple of examples of some of the things we're doing, if we talk about the collaborative way, we need to make sure that we are working with other people. And I use the example of the oral health training for midwives. It's been a hugely successful program as part of our Healthy Families, Healthy Smiles program that's been funded by the Department of Health. And there's a large number of midwives right around Victoria now that have been trained to talk to their to the expectant mothers about their oral health, to screen them, to refer them on so that they can be referred on to practitioners for care, and to actually provide advice, because they're really aware of the fact that the health of the mother's mouth is pretty important so that she'll go to term in her pregnancy, etc., but also that her oral health will have a significant effect on her children's health. So we managed to, kill two birds with one stone by getting to that person before they have their child. And so the midwives, we know that those about-to-be mothers go to the midwives, and as a result, those people can be absolute champions for us. And that's a pretty important thing for to have those people as our, I suppose, oral health champions into the future. So that's one example where you can get really good collaboration. Getting back into the maximising the workforce scenario, I have a really strong view that all members of the dental team need to work to their full scope, and also in agreement with Brendan, the fact that if people can work to the higher end of their scope, it can be a much more rewarding experience. And so the sort of examples that I would use is that I would see, and this is sort of more along Brendan's line of the assistant side of things, is that DAs would do the radiographs, they'd do the fluoride application, they'd do the oral health promotion, all with training, and all having, being appropriately skilled to do that. So I am talking about people who are trained and competent in what they do and do it really well. Prosthetists providing dentures, and I think that's one space where we've probably worked that pretty well out throughout the whole of Victoria. But each particular area you need to determine, have you actually got it right in your particular clinic? Oral health therapists and dental therapists treating children. In Victoria, we still have a large number of dentists treating children, and that's actually unusual. In other states, there will be a much higher proportion of oral health therapists. And so one of the challenges is, why have we got a dentist who could be treating other people that are outside the scope of practice of the oral health therapist? Why are they treating children? I accept the fact that there are some work that needs to be done by dentists, but the majority of it can be done by oral health therapists. Also, with respect to oral health therapists and dental hygienists treating perio, once again, we have a lot of dentists who are doing scaling, etc., and we should be looking at transferring those services over. And we've now got oral health therapists who can treat adults that have been through the advanced training. They can also take over and do some of those simple restorative care and examinations and initial consultations with patients. So there's some real opportunities. So I'm going to just give you an example, I suppose, of one person. She's my pin-up girl at the moment. I don't know whether she's here at the moment. Yes, she's right at the front. So this is Vang. She's at North Richmond Community Health Centre, and I get to see her reasonably regularly, either running through the hospital, working in the clinics, learning to be a dental hygienist, or at North Richmond Community Health. And I think she's a really great example of where she's gone to and the success that she's had. I mean, if you ring North Richmond to talk to her, you probably won't get her, because she's either out in the community talking to people, she's out talking to children, or at smoking cessation programs, or there's just this never-ending supply of things that she's actually attempting to do and making a real difference. She started off doing her dental assistant course. She went on and did a Cert 4 course in oral health promotion and radiography. And once she achieved all of that, she then went on and started to doing her hygiene course through RMIT. So she just keeps on going. Heaven only knows where she'll go to in the future. But one of the things that is amazing is that the care that she provides to her patients and the opportunity that she's been offered to allow her full scope of practice to be used at all times. And she works in a really close collaborative environment with the rest of the team at North Richmond Community Health Centre. So it's a really good example of how you can get other people to do the job that traditionally was done by dentists. So I think Vang's a really good example of what can happen when you're in an environment that allows it, and people with real a keenness to take it on. So just going back to some of the evidence-based and prevention side of things, we want to make sure that whatever we do is cost-effective and less invasive. So we want that early intervention and a focus on prevention. But we need to make sure that we aren't doing a whole pile of preventive things that don't make people better off. And I use examples of, some people. I was talking recently with somebody who was saying, these people come in and they do fissure sealants on every tooth in the mouth for all children. This is not in our environment, but in other environments. And those are the sort of things we've got to make sure we don't do. We've got to make sure that when we are applying some sort of early intervention or preventive model, it's actually going to make a difference for people. And the other thing that I want to talk about is the experience of things like the Hall technique, this sort of small stainless steel crowns that are going on, fairly seriously decayed teeth for children. One of the things that, and I'm particularly aware of this one because when it was first mentioned, it first came about the trial that's happening at the moment. And when it was first suggested was probably when I first came back into this job. And I remember thinking, this just won't work. It was all my old views were coming on. It was sounding a bit strange because I used to think of how much time I used to spend doing stainless steel crowns, getting this perfect fit. And this technique is so simple and so loved by everybody. And I don't remember it being a very loved experience when I used to do them in the past. So one of the things I wanted to do is just to talk, I've got a couple of quotes here, but from a clinician's point of view, the clinicians have been overwhelmed by the type of response that they have got from it and how easy it was. And it's been interesting too that clinicians have also gone, they started off, no, I don't want to do this doesn't sound right, it's just not what we were taught to do, and then have been absolutely transformed by firstly how simple it is, and secondly by the response they've had from children that used to have to go in and have GAs to have the work done. So you end up with recognising that there are different ways to do things and we need to be constantly looking at it. And when you take something that used to be a 45-minute appointment to an hour for some people, or a GA, which was probably the lesser of the things that you'd want to be able to do, you'd find that you've got a 5 minutes to probably about a 10 or 15-minute appointment. So all in all, it's a real win for people. And so from the actual kids, one of the things I've been amazed about, particularly when we're in an environment where everybody wants white teeth, how excited these kids are about having a little silver tooth. But and I saw a really great scene the other day when I was visiting North Richmond, and there was this little kid that came along, and she came racing in. And this is a person who would have had a GA for this care, was the first child in the trial to have this little crown on, and she raced up to the dentist and gave him a big hug and everything. And I thought, wow, I don't remember having put stainless steel crowns on people and they'd come and give me a big hug. So it really is different, and it's one of the things that there's lots of other things like that actually will make a difference for people, and we've got to look at it. We need to be patient-centred, make access to care really easy. As I've said before, we make it, you need a medal if you can get through our services. We need to be patient-centred and patient-friendly. And I want to just use one example of Ballarat Health Services. They had a lot of elderly people that just weren't able to access care for physical reasons, it was too hard, etc. They actually now go out and provide treatment in the aged care centres. And they've treated over 170 patients so far. And a really good model where they've said, well, we're going to be flexible, we're going to go out to that community and provide the services there. And I know that there are examples right throughout this room of people that do that sort of thing, where you've found innovative ways of providing care to a group within the community that currently don't get it. So in summary, I'll just quickly go through this and say that we need to develop these models of care. It's going to take us some time. It's not going to be quick. But it is important that we are intellectually challenged to go through and say, how are we going to do this? And it's going to be different in different environments. I recognise that. There's probably no one size fits all, but the principles are identical, absolutely identical. We need to extend our reach to more patients and more people that are on that eligible population that we need to treat. We need to provide high-value care, absolutely. We've got to stop doing those things that are of low or no value. We need strong clinical leadership. Without the clinicians leading this, we won't be able to make the changes. You are the ones that drive the costs, you're the ones that drive the decision-making, and that's why we need you to be really, really strongly involved in it. We need patient engagement too. We need to have that focus very strongly, and we need to optimise the workforce, and I think that's absolutely essential if we're going to have a cost-efficient model of care in the future. And lastly, we need to collaborate with other care providers. So a lot of work ahead of us, but it is really exciting, in really exciting times, and we should take that opportunity. So I look forward to working with you all in the future, because I know that we're all going to be working pretty hard on moving forward. So thank you very much.